causes of deaths worldwide, claiming millions of lives each year, and India carries a significant burden of this disease. Despite advances in critical care, timely diagnosis and intervention remain the key challenges. Now, today's webinar and hence is dedicated to exploring these issues hands-on, which are understanding the true burden of sepsis in India, discussing current diagnosis challenges, and how do we deal with them? What are some of the expert opinions to deal with these issues, exploring innovative solutions and strategies to bridge these gaps. Now, BD, as you know, all of you would be knowing, has been advancing the world of health, and what is it remains a fact is this has been for over 100 years. We are a organization that has been contributing to the world of health for all these years, and very proud to share that BD is pioneer as far as blood culture diagnostics is concerned. So we have over 40 years of experience in developing blood culture instrument, providing to the market the market leading solutions and constantly innovating technologies. So you can see the legacy of the blood culture with relation to BD on the screen. In 1968, BD was first to launch an automated blood culture instrument. In 81, we commercialized the resin technologies. With 97, we introduced the lytic anaerobic media, which still remains one of the most sought after media for anaerobic and facultative anaerobic detection. And in 2012, BD was first to develop blood volume monitoring to meet the CAP requirements. 2015, BD again introduced satellite culturing, placing instruments in remote location to minimize the delays in blood culture processing and promoting optimal patient management. And this is with our small footprint system, which is called as the Backtech FX40. So BD now continues to invest in development of next generation blood culture solutions, data management, and total lab automation. On this slide, you can see the end-to-end solutions that we have as far as blood culture collection to processing to the analytical phase is concerned. The pre-analytical bits with the BD Chlorpep and the Vacutainer Ultra Touch and the SLBCS blood collection sets. Then we have the blood culture instrument. The FX is a series of blood culture instruments along with the blood culture bottles. There is a range of media that comes with the instrument. And now we've introduced the informatics software by the name of BD Synapses, which gives you near the patient insights on various parameters around blood culture. At the touch of a button. So this is the offering that we have from BD. Now, I will hand it over to Simran, and over the next 1.5 hours, you will be hearing from leading experts from all across the country to share evidence-based insights, practical approaches, and potential pathways forward. So I hand it over to Simran. Thank you.
Thank you so much, Dr. Neha. And thank you for setting the context so aptly for the session we have now. Moving ahead, next, our speaker is Dr. Siddhant Shetty, infectious disease specialist and general physician, and currently the clinical lead of infectious disease at Niramaya Health Associates. Dr. Shetty will be speaking on heterogeneity and complexity of sepsis presentations, discussing the clinical variability in symptoms, diagnostic challenges in atypical presentation, and importance of timely blood culture. So over to you.
Thank you very much for inviting me to present. I'm Dr. Siddhant Shetty. I'm an infectious disease specialist. The complexity of sepsis presentations and the challenges that we deal with tackling this. So let's start. So next slide. So the sepsis 3 definition per se. So the sepsis 3 definition, which came in 2016, defines it as a life-threatening organ dysfunction caused by a dysregulated host response to the infection. Okay, so it might be a suspected or proven infection, uh, probably in the blood from a specific source, along with organ dysfunction. Organ dysfunction is defined as an increase in 2 or more points in the sepsis organ failure assessment SOFA score. And septic shock is an advanced version of this, where a subset of sepsis where underlying circulatory, cellular, and metabolic abnormalities with a greater risk of mortality than sepsis alone, defined by vasopressor requirement to maintain a MAP of more than 65 despite fluid resuscitation plus lactate of more than 2 ml. Many will call this as severe sepsis also. If we go to the next slide. Uh, here. So the major cause of mortality is from sepsis, something that we usually deal with. Next slide. And it's all about catching it on time and managing it appropriately within the bundle provided. It can be caused by any type of infection. Just bacteremia does not define sepsis. It has to have multi-organ dysfunction. That is an inflammatory syndrome from the body. And in severe sepsis, there will be hypotension. You can have SIRS and MODS without sepsis also, as we will see in the mimics, which we'll discuss later. Okay, so it's not just specific to sepsis that way. Next slide. So the physiology is there'll be an infection, there'll be a source. Once it breaks the barrier of the location of the infection, it may be urine, may it be lung, may it be abdomen, may it be skin soft tissue. So suddenly spreads into the bloodstream. Once it gets into the bloodstream, gets encountered by the immune cells, there is endothelial activation from the bacteria and their toxins, which leads to microvascular dysfunction along with complement activation, dysfunction and cascade, leading to microthrombi being formed everywhere in the body, along with neutrophil extravasation into the vessels and into the target site, leading to all these cumulatively lead to multi-organ failure and an altered host contributes to the severe sepsis. Next slide. So it's important to understand the times onset, whether it's early versus late. Patient come from the community, is it hospital acquired or has a recent hospital exposure or is in the ICU, which is nosocomial sepsis. And most important to identify the focus and to deal with it. Next slide. So the common sources, identifying the focus of sepsis is probably one of the most important things to be done in the first 30 minutes to an hour, where the sources can be anywhere ranging from urinary tract, urosepsis, skin soft tissue, that is cellulitis, necrotizing sources like cholangitis, a perforated viscous appendicitis, diverticulitis, along with pneumonia, line-associated infection, endocarditis, or meningitis. Next slide. So the presentation comes in same mnemonic where there is shivering, that is chills, fever, or feels very cold. There is extreme pain or generalized discomfort, worst ever as described by the patient. There will be pallor, there will be discoloration of the skin. Patient will be sleepy, drowsy. That's one of the earliest signs of sepsis. I feel I might die. Okay, that's a sense of impending doom and shortness of breath. That will also come in the SOFA score later. Next slide. And next slide. So diagnosis is consisted by all these, where a clinical assessment to identify systemic features, the syndrome, risk factors, altered sensorium, urine output, suggesting kidney failure, liver function assessment, ileus, adrenal insufficiency, hyperventilation, hypotension, cardiopulmonary complications, neurologic complications, and coagulopathy, especially signs like a purpura petechial rash, indicating severe sepsis. Next. So the type of the underlying infection, the individualized approach, where some infections are more likely to cause a septic shock, need actually aggressive management. The degree of hemodynamic instability will be quantified by four features, where the heart rate and the systolic blood pressure, the vasopressor required, and the evidence of end or macrophagia, that is urine output, or skin, the dampness and the coldness of the skin. Also, degree of hyperlactatemia. So lactate is something which can get bedside in an arterial blood gas. Can we move on to the next slide? Yeah. Yeah. So the three scores that we have to know of when a patient comes into a casualty or presents to you. For quick bedside assessment, the first score is Q-SOFA, the second score is the new score, which we'll discuss in the second slide. So the Q-SOFA consists of three parameters: respiratory rate of more than 22 breaths, altered mental status or GCS of less than 15, and a systolic blood pressure of less than 100. And two or more of, so any two or three of these three parameters, if it's positive, then it is a positive for early sepsis. Next slide. We come to the news score in the next slide, where it's a national early warning system. It's an aggregate score of 6 parameters, up from 3 in the earlier score, where you have respiratory rate, oxygen saturation, systolic blood pressure, pulse rate, level of consciousness or new confusion, and the temperature. And a score of 7 or more is considered high risk, 5 to 6 for medium risk, and 0 to 4 of low risk for early sepsis. So Q-SOFA in bedside is much more preferred and more validated than the new score, but this is also used. Next slide. Once we have some basic parameters with us, blood work, then we can move on to the scoring system for SOFA score, which also needs the liver function, that is bilirubin, the renal function, that is creatinine, and the urine output. Also considers the cardiovascular inotropic support requirement and the PaO2 by FiO2 ratio on the ABG. So this is one step after the patient has been resuscitated, labs have been sent, is when you can calculate the SOFA score, and organ dysfunction is present if SOFA score is more than equal to 2 above the baseline. And next slide. The SOFA score is not diagnostic of sepsis, but it prognosticates sepsis, where if the SOFA score is high, it means that the patient has a very high risk of dying from sepsis and the prognosis is poor. Okay, so not for diagnosis. Q-SOFA and NEWS are used for diagnosis of sepsis. Next. So lab workup, what all you need to send when you have suspected sepsis? Now that you've gone through Q-SOFA and NEWS, now you want to send workup. So lactate, important. We've discussed this in the last couple of slides. Two sets of blood cultures, very important for culture of any line which is in place for more than 48 hours. A hemogram, CBC, ESR, total counts, differential counts, blood sugar, liver function test, kidney function test, LDH. Suspected infection biomarkers like procalcitonin, CRP, beta-D glucan, and an imaging as required. An X-ray, a sonography, a CT abdo-pelvis if no definite source has been obtained. Next slide. So additional tests which can be done as per the suspected syndrome. After doing a good clinical examination from top to bottom, you will have a differential diagnosis consisting of one of these: meningitis, pneumonia, endocarditis, line infection, cholecystitis, for example, and you will work up accordingly. For example, get a 2D echo for endocarditis, or a lung POCUS or a chest X-ray for pneumonia, and cultures from the lines in a line infection, a sonography for a cholecystitis or a CT if needed, and LP for meningitis. Next. So to complete the differential, again, cholangitis, if it's a suspected C. difficile infection, a perforated viscous, again, can be diagnosed on a USG or a CT. A urinary tract infection can be diagnosed via urine analysis, USG, or a CT scan. Streptococcal toxic shock and necrotizing facial can be just doing a blood culture and examination. Sepsis mimics that is hypotensive, not all that is fever is always sepsis. Let's go to the next slide. This is a summary of all the sepsis mimickers which can be possible in the acutely ill patient. We'll compartmentalize it into the 4-5 common differentials in the next slide. Can we go on? And amongst these, I feel the most important ones are actually adrenal crisis and pancreatitis. So just yesterday, I was dealing with a severe pancreatitis patient who was in shock, but there was no evident focus of bacterial infection. The procalcitonin was normal. The patient was in respiratory distress, and it was all pancreatitis associated and not sepsis. And all these confusion, whether the patient has a sepsis or a sepsis mimic, leads to unnecessary use of antibiotics also and delayed diagnosis and delayed intervention of the primary cause. Adrenal crisis itself is a very common problem where patient who's been prolonged hospitalized, has got steroids, immunocompromised, can develop partial or complete adrenal insufficiency when as soon as the steroids are withdrawn or the patient is goes into acute stress, the adrenal response gets blunted and leads to a sepsis-like picture where the hypotension is not accompanied by other systemic features of sepsis. Other mimickers are anaphylaxis, DKA, chronic liver failure, as well as cytokine release syndrome. This is something that we are now dealing with more and more as we are doing immunotherapies and CAR-T therapies, etc., where this is seen when the treatment is attacking the body cells. Next slide. So key principles are early diagnosis, source control, preferably within 6 hours, organ perfusion with fluids, vasopressors, oxygen management, antibiotic therapy in the first hour, very important. Okay, as the sepsis bundles keep reducing from the 6-hour bundle to the 3-hour bundle to the 1-hour bundle, it's become more and more important to diagnose and give the first dose of antibiotic as early as possible for better outcomes. And fluid resuscitation goes without saying. The first 3 to 6 hours are the most important in sepsis management. Next slide. So common fallacies in the blood culture diagnostics. Now, this is something very practical a discussion which we'll be having over the next 4-5 slides. So when a patient comes to the casualty, and something that I've seen in my experience and something that I'm seeing on a daily basis is why is the diagnosis getting delayed and why is the management getting delayed? So first of all, a diagnosis most commonly when I get references when I see patients are blood culture negative sepsis. Now, the problem with that is it's not really culture negative. It is because of the logistical problems which come in between, where in the casualty level or in the ICU level, they may not be culture bottles or media available. So blood cultures are not drawn prior to antibiotics. They were not sent on time. The timing was wrong. There was inadequate sample quantity. So many times I see nurses collect cultures for blood cultures, and they're just putting 5 ml, 6 ml into a culture bottle when the adequate amount is at least 8 to 10 ml per bottle, which is very important. There's also the problem of unsterile techniques and contamination in the blood cultures, where I'll come to a case regarding this in some time. There's a delay in transportation. So many times I see the blood culture being collected and then kept bedside, and then it reaches the lab much late. So it gets incubated much later and leads to delay in the diagnosis. And because of this contamination problem, there is a conundrum whether the organism, because it's quite sensitive also, the blood cultures that we have today, the automated ones, whether the bug is actually a true bug or a contaminant, depending on the sterility of the technique that we are using. So let's come to a few cases. Next slide. This is a scenario that we see quite on and off, and this is a case which I've dealt with quite recently, where an uncontrolled diabetic 67-year-old female with recurrent UTIs in the past who had received multiple antibiotics orally and IV in the past, presents with fever and altered mentation, and had pyuria and had peripheral blood leukocytosis. A sonography showed bilateral pyelonephritis and a urine culture and a timely blood culture, fortunately, was sent. And the reference was that patient was empirically started on meropenem because she was quite sick and she had received multiple oral antibiotics. And something that they didn't uh, evaluate on history was the patient had received meropenem earlier, but was still started on the same antibiotic. Next slide. The urine culture came back as a pan-sensitive E. coli with a significant colony count, which is more than 10 raised to 5, which establishes a diagnosis of a urinary tract infection. However, the patient was not responding to meropenem. So that was a little odd, which was why we were referred in. So on a suspicion, we were asked whether the antibiotics need to be stepped up to a CRE cover, but we had no evidence. And a day later, the blood culture also flagged positive. But to our utter dismay, go to the next slide, it was actually a pan resistant or a multi-drug resistant or a carbapenem resistant E. coli in the blood. So this proves our point that even if you have identified a source, if you have sent cultures from the source, it is very, very, very important to send parallel blood cultures since infections are not uni-strain. There is heterogeneity in infections. There can be multiple strains of bacteria causing the same infection. And it is not necessary that the bacteria that you have isolated from the source will be the same as the bacteria that is causing the sepsis. It's very important to send as many cultures as you can to get the accurate diagnosis. The patient was stepped up to ceftazidime combination and made a good gradual recovery. But if we had not sent a blood culture, we would have been stuck for a diagnosis. We would have gone for probably gram-positive covers, fungal covers, without understanding that this is actually a MDR in the blood, which is not consistent with the strain in the urine. Let's come to a next stage, next case. This is again something that I see quite commonly, that I'm called in to see a patient for another reason. And I see that the blood culture has grown this particular bug and the patient is on empiric, assumed to be directed teicoplanin. Can we move to the next slide? And is told to have Staphylococcus bacteremia. But if you go into the subspecies, if you look at it, it is actually a Staphylococcus epidermidis. So we have to understand what is a true bug and what is not, which is a skin commensal. So Staphylococcus epidermidis is a coagulase negative staph. There are other species like Staph capitis, hominis, hemolyticus, etc., which line the skin. So if your collection technique is not sterile, it's not proper, then you can actually contaminate the blood draw with these surface organisms and then get misled to treat these kind of bugs, which is not necessary. And the diagnosis changes completely. Okay. We can come to the next couple of slides. This is the last case where this is a 45-year-old male who was a CKD on dialysis through the catheter, was having fever and chills post dialysis, and who was not was started on empiric meropenem and teicoplanin, but there was no response to this treatment. Now, if you take the anecdotes from the first case, we are dealing with a lot of multi-drug resistant, even carbapenem resistant Enterobacter CA in our hospitalized patient, dialysis patients, etc. So again, that was something that we were suspecting. So the conundrum was whether to step it up to ceftibactam astronam combination or no. However, since timely blood cultures were sent, and now since we are having so much of healthcare exposure and dialysis catheters and water exposure, now there is a increase in non-lactose fermenters into our system, where if you move to the next slide, the blood culture came positive for this bug called as Stenotrophomonas maltophilia. It is now invading our ICUs, which the perplexity of this bug is that it is intrinsically carbapenem resistant. It is very intrinsically carbapenem resistant. So actually getting a blood culture diagnosis for this bug is very, very important because it is actually susceptible to much lower drugs like higher tetracyclines like minocycline or cotrimoxazole or levofloxacin. So to prove the point, timely blood cultures, very important, adequate cultures to and giving the antibiotic on time within the first hour is of the most essence, and that cannot be replaced. I think that's the end of the presentation. Thank you very much.
Thank you so much, Dr. Shetty. Thanks a lot for that amazing presentation and sharing your insights over this and highlighting the diagnostic challenges that often delay the treatment. Next, we have with us Dr. Shalab Malik, Director of Microbiology and Serology, Molecular at Dr. Lal Pat's Lab, Delhi. Dr. Malik brings decades of expertise in diagnostics, microbiology, and has been instrumental in advancing molecular diagnostics techniques in India. He will be sharing his insights on rethinking blood culture diagnostics, sharing evidence based practice for blood culture collection, and the role of BD's specialty media in improving outcomes. Dr. Malik, over to you now.
Okay. Thank you, Simran, and very good evening to all of you. So, my topic today is rethinking blood culture diagnostics, evidence-based best practices. Next slide, please. Next slide, yeah. So, sepsis we know is a reaction to the infection, and what happens? Not only the agent which is responsible, which can be bacterial, fungal, or viral, or maybe unusual pathogen, but the response of the body to this, where it starts damaging its own organs, etc. So it is a reaction or to the various etiological agents. And clinical features have already been defined by Dr. Siddhant, so I will not discuss it again. So only thing is you remember that sepsis is not only because of bacteria, but it can be due to fungal, viral, or parasitic, etc. Next slide, please. So if you look at this slide, around 50 million cases are there of sepsis, 11 million deaths. That means 1 out of 5 patients are dying, despite the fact that we have enough antibiotics, good ICU facilities, diagnostic, etc., which of course have brought down the incidence by 37% if I talk from 2000 onwards to the present day, and decrease the mortality by 53%. So blue side of the map is the high burden countries like Africa, Asia, etc. And light green and yellow are the low incidence countries, that is high income countries like Europe, US, etc. Next slide. So 1 in every 5 deaths worldwide are associated with sepsis. 85% occur in low or middle income countries. 2 out of every 5 cases are in children. And of late, as our population is aging, again the other end of the spectra, that is old age group beyond 60, 65, are another strong group of people who encounter the sepsis. Next slide. So if I talk about India, where again the data is erratic and not consistent, but still whatever data I could obtain, it says 1.5 million cases each year, somewhere around 500,000 to 700,000 deaths. In United States, it is 1.7 million, and every one case is diagnosed every 20 seconds. So half of the cases we are not able to establish the etiological agent, despite the fact that we have battery of investigations available now. So delayed diagnosis result in fatal outcome. Next slide. So if you look at this slide, on the x-axis, we have the time period. So the moment you take lot of time in diagnosing it and finally coming down to the treatment, the survival rate falls. And especially the first 12 hours is a critical window where every 5 minutes, 1% mortality is increasing. So the gist of the story is diagnose early and target precisely. Unlike empirically targeting results in haphazard treatment, and many times you go overboard as far as antibiotics are concerned. Stewardship goes haywire. On the economic front also, it amounts to billing, etc., overstays in the hospital. Next slide. So now the patient, when it comes to the emergency department, so what are the questions in the mind of clinicians? So do I prescribe antibiotics straight away? And what further test should I order? Should I just order blood culture, or should I order other markers also, biomarkers also along with it, or should I order other molecular test also? So do I admit this patient straight away? Because see, every sepsis is not something which will require treatment, which will require admission. So to address these needs, test should be accurate one, it should be precise one, it should be targeted. So you know the exact agent and you shoot it. So fast enough to fit into emergency department workflows. Next slide. So what are the tools for bloodstream infection? Utility of blood culture is increasingly undermined. It is slow, it is prone to contamination and is often underutilized. So of course, blood culture is there with us since more than 100 years after Robert Koch and Louis Pasteur demonstrated that you have to grow something, and then that if you are able to grow it successfully, that is responsible for the disease. So it started from there, and then after antibiotics, when they were discovered somewhere around 1930s, 1940, etc., the curiosity grew that what is the bug and which antibiotic has to be used. Next slide. So in this session, I want us to rethink the role of blood culture. So for the patient, how quickly we can reduce the time to diagnosis and ensure survival. From antibiotic stewardship point, we have to ensure antibiotics are used wisely because we are already aware the pipeline is limited. Fewer antibiotics are discovered, and again their availability is question mark. For healthcare economics, how can we reduce the hidden cost of prolonged ICU stay, avoid contamination and overtreatment? Next slide. So historical perspective, I was mentioning that how it started all from Robert Koch and Louis Pasteur, and then the good thing happened somewhere in 1970s and 80s when introduction of automated continuous monitoring system was launched in Europe and United States. And that changed the ball game. Actually, earlier you have to inoculate it into broth, and then somebody will take out all these tubes, inspect, look for the turbidity, then subculture it. So lot of stuff was getting delayed. You were getting answer in days, whereas this is a matter of hours and minutes. So and the ultimate outcome was also very limited in the pre-automation days. So automation changed it, and we started seeing the continuous monitoring of these blood culture bottles, which culminated in positive results. But the fundamental principle did not change. We are still dependent on the growth to happen, and then growth has to crystallize on agar plate, and from there you have to carry out identification and sensitivity. So historically, blood cultures have gone from weeks to days and roughly a day in best case scenario. But the need of the hour is that we quickly answer. The, the quest is that the same day reporting should happen. So how it will happen, how this so-called gold standard technique can be further supplemented with the help of other tests, we will see in the further aspect of this presentation. Next slide. So what are the current challenges in the blood culture? So one of the thing is antibiotic treatment. Most of the patient by the time they land in your hospitals, ICU, etc., they have already taken some sort of antibiotics. And we all know antibiotics interfere with the growth. It delays the growth. And many times it is not targeted also correctly. And at times you overusing it when it is not indicated. The next issue is fastidious organisms, like let's say brucella, let's say rickettsia, or let's say funguses, etc. So these they require time. Unlike the standard bacterial cases, which you will get some answer in 2 to 3 days, they require different incubation periods. Their protocol is different. Their media requirement is different. So you are going to miss these organisms. Then the next thing is low level of bacteria. If the bacteria is very low and if some transportation lapses have happened, viability of bacteria is under question. Again, it is going to take time and many times you will get a negative answer. Then lax-sided protocols while collecting the blood. If you are not following proper protocol with chlorhexidine and alcohol, etc., you are not wetting it. Touching the site wrongly can lead to again contaminations. Time lag. So despite the fact today most of us are using automated system, it will take time to flash it positive and then again you have to crystallize it on agar. And then if you are going to use biochemicals or you are going to use other automated identification system, it will take time to identify it. Similarly, antibiotic sensitivity will take another day. So by and large, you are getting answers in 2 to 3 days if you practice conventional microbiology with automation. Diagnostic gaps are there and volume effect, yes. So if you are not doing justice to the appropriate volume which is required, somewhere around 10 ml in case of adults, and we all are aware now there are enough publications to demonstrate the fact that with each volume jump, there is a jump in sensitivities. So if you are, let's say, taking 3 sets of 10 ml each, pair of blood cultures, your sensitivity will jump to 96%. Next slide. So what is the clinical impact of all this? So we know contamination, if somebody presumes that this is the culprit, then we know the patient is getting unnecessary antibiotics, prolonged stay is happening, but bills are jumping over here. Delays will lead again to empiric type of a treatment, especially first 72 hours. So critical pathogens are missed. We have already covered that and how volume issues affect the preventable diagnostic failures. So the net effect is clinicians are often forced to treat blindly. Empiricism becomes entrenched and antibiotic stewardship suffers. Cost rises and most importantly, patient pays the price. Next slide. So what are the innovations in this blood culture technology? So today my motive is not to degrade the blood cultures, but to see how it can be aligned with the modern technologies and modern testing which is available with us and how we can speed up. So there are automated systems, good resin-based media is available which can neutralize the antibiotic, even right up to the latest antibiotics which are being used day in and day out. Then MALDI-TOF, which will again shorten the identification period. Unlike the previous methodology that somebody is making a gram stain and then communicating to the clinician that look, GPCs have been grown. So GPC is a very broad term. We all know what it boils next day. It may be micrococcus, it may be staph, it may be something else. We don't know. But with MALDI-TOF, you will tell exactly in 1 minute time that what you are dealing with. So at least the isolate which you are going to target is available with you. Then further multiplexes PCR panels are there. Targeted panels are also there, which we will discuss further. And again, antibiotic resistance molecular panels are also available. So all this can be integrated and the blood culture can be strengthened. Next slide. So this is how the journey starts from collection to sample testing to actionable result. So we have seen how you have to take it in bottle and park the bottles in good enough time and you should not refrigerate it, etc. You have to maintain it at around incubator's temperature. And finally, the result which will emerge for ID and sensitivity will be translating into the actionable result. Next slide. So timing of collection is very important. Order of blood collection, skin disinfection, collecting the blood culture bottles, number of bottles, number of sets you are going to utilize. So what happens in India? Most of the time people take just single bottle. That also is very hesitant approach. But now things are changing. Uh, Everybody is getting educated, and at least paired blood culture system is being implemented across. Next slide. So this slide shows how you have to take aseptic precautions before you collect the blood. And volume, as I mentioned, in case of adult, it will be 8 to 10 ml of blood per bottle. In case of children, it will be 1% of the total blood volume. So for children, we have a special and a PET special bottle, which has to be used. Because there, the media strength is different compared to the adult bottle. Dilution factor is different. So that is why we have to go accordingly. Next slide. So volume plays a very important role, and single blood culture, in my observation, just gives you positivity of around 8%. And sensitivity is also very less, much less than 20%. So as you increase the volume, the yield of detection increases by around 3.5% with each additional milliliter of blood cultured. So if you take correctly 3 sets, your sensitivity will shoot beyond 90%. Next slide. So the already markings are there on the bottle, and also the systems are now enabled where they can easily flash out if suboptimal volumes are there. Next slide. So this graph again shows how the each volume increase, how it is translating into better yield. The more the volume, the better the yield. Next slide. So how many cultures we should collect? Minimum paired blood culture. So it is a good practice if you take a combo of aerobic and anaerobic, and if you practice the 3-set methodology, the yield will be fantastic. So sensitivity is around 96 to 98%. Next slide. So this is again the meta-analysis where peripheral venipuncture resulted in a lower blood culture contamination rate than the catheter blood draw. So avoid taking it from the lines which are already there because most of the time is dilution happens over there, and you don't get a good yield. Next slide. So when you are going to do battery of tests for someone where other investigations are also there, so first should be blood culture bottle, which should be inoculated, followed by the other biochemical test. Next slide. So avoid this taking from already the intravascular device where it is already there. So blood culture should be obtained through fresh venipunctures rather than indwelling intravascular devices. That is important from decreasing the contamination. Next slide. This is how the broth is there and how resin bits are there in this. Anticoagulants are also there, which will prevent blood from clotting and does not interfere with entangling of the bacteria. Next slide. So now let us discuss something about the innovations and paradigm shift which has happened. So automation already started, as I mentioned, from 1980 onwards, where we have got a fluorescent automated system. So what happens when the organisms are multiplying? There is a consumption of oxygen, increase in carbon dioxide, and that changes the pH. And moment the pH changes, the fluorescent indicator which is present at the bottom of this bottle gets activated. And these blood culture systems, they are monitoring this fluorescence on the basis of every 60 minutes or 30 minutes. And moment it crosses the threshold, you get a positive response. So this was the first step. So then it was layered by the artificial intelligence. So what artificial intelligence further added, that it was able to analyze the growth patterns. What is the lag phase? What is the exponential phase? Whether it is inconsistent, whether the kinetics are dynamic, etc. So this helped us in telling whether the contamination has grown or whether the pathogen is involved in causing the disease. Now, further, with the help of AI, the integration of the blood culture result with the hospital LIS has also happened, where it takes into account all other vital parameter, other tests, plus the blood culture report and give a advisory or alerts. So this improved the communication to the treating doctors. So dashboard can integrate lab results with the hospital's electronic medical results. Intelligent real-time and action-oriented diagnostic is happening. It is a reality now and much more rampant in the western part of the world. In India also it is picking up, and you will see a lot of AI and automated activities in the coming time. Next slide. So next quest was rapid identification, that we don't have to wait for agar crystallization and all. So systems have come where directly from the positive bottle you can subject it to either phenotypic way of testing. That is, you load it in microfluidic chamber and real-time growth monitoring happens in the presence of antibiotic, and which finally with the algorithm is translated into MICs. So this will change how the sensitivity is today. Today's automated system is reported next day, you will get it in same day. Let's say if somebody has loaded morning 11 a.m. So by 7 p.m. you will have both IDs and sensitivity in your hand. So MultiTop has also changed the thing, as I mentioned, how it can identify it and make your treatment precise because you know the organism in less than a minute's time. Then on the other side of the scale are molecular tests like BioFire is one, or other multi-arrays are also available, which have got common targets, which the infections which we deal day in and out, and along with AMR resistance genes. So this also you can be loaded. They are cartridge based test, and you get a quick answer in 60 minutes time. So you have some sort of guidance. So this will be no frontliner. So a good automated molecular test which will give you quick answer in 60 minutes. And phenotypic culture will again be important because you want to understand salt by salt of antibiotic, what is happening to each antibiotic, what is the MIC, etc. So their role will also be there, and this will give you preliminary guidance. Further, we have other molecular tests like CARBAR expert, which can talk about carbapenemase is there or not. Again, ESBL based test, MRSA based molecular tests are also available, which can give you quickly possible answer in the same day scenario. Next slide. So new platforms are one, Accelerate Pheno system, which is already available, FDA approved system in the western part of the world. Molecular assays, I have already highlighted how the window of opportunity in sepsis is measured in hours, not days. So we are slowly moving towards that direction so that we get the right drug, right time, and right type of treatment in the fastest possible time. Next slide. So beyond cultures, so suppose I am not able to define the site, I don't know what is happening. So this metagenomic next generation sequencing has further changed the scenario. So earlier the biggest challenge was that when you draw the blood, lot of human DNA is there. So that is a noise. So now we have got fantastic extraction capabilities where we can just filter the microbial DNA. So that is the metagenomic material which is there. So this comes, so the theory behind is that organism, if it is lost anywhere in the body, either it will secrete the nuclear component in the blood, or the immune system will damage it and make it secrete. So we catch hold of this, sequence it either by the nanopore type of sequencing or Illumina sequencing, and it is a white book which comments about not only bacteria, fungus, and viral diseases also. So as this technology use will grow across, you will see that bacteria is not the only culprit in causing sepsis, infection, etc. Further, AI-driven integration is there, how it is able to analyze the graphical pattern of growth and differentiate between the contamination and the pathogen. Then host response biomarkers are there, like in United States, septicite is one, which can easily differentiate between the microbial agent caused inflammation or non-microbial inflammation. Procalcitonin, all of us are aware how this is helping us in differentiating between the bacterial and viral illness, and also one of the good tools in escalating and de-escalating the antimicrobials. Next slide. So what is the clinical impact? So earlier targeted therapy is the reality. Studies show therapy modification, escalation or de-escalation occur 24 to 36 hours earlier compared to the conventional method. Improved antibiotic stewardship, early de-escalation from broad spectrum empiric coverage reduces resistant selection. Outcome signals. Early data suggests improved time to effective therapy, reduced LOS, and cost saving. So finally, diagnostic stewardship, a call to action. Over ordering due to vague system symptoms. Bundle pressure versus clinical judgment, standardized indications and volume protocols are needed very much. Next slide. Rapid susceptibility testing, again, direct from the blood culture bottle is a possibility. Already protocols are available. But again, see, this is also taking overnight. So as I mentioned, microfluid chamber technology and real-time monitoring of the bacteria in the presence of antibiotic is a reality, and which shortens the time somewhere from 3 to 6 hours. Clinical integration and stewardship, microbiology labs in value-based care, collaboration with emergency department, ICU, infectious disease and pharmacy, interpret results in clinical context. So all these things right from the culture to your CRP, procalcitonin, and then septicin test, IL-6 or protein markers, etc. All everything can be integrated along with the molecular science results, and you get a comprehensive answer which is quite precise and leads to the rightful practice of antibiotic stewardship and good outcome of the patients. Next slide. So something about biomarkers, I will also talk, like the graph you can see now, the 4 type of possibilities are there as far as procalcitonin is concerned. So on my y-axis is infectivity graph, on my x-axis is the sickness. So if the sickness level is high and procalcitonin is also high, so you know that you are dealing with a typical bacterial case. But then there are some gray areas. There are some situations where procalcitonin is high, but sickness is not that much. And similarly, sickness is very high and procalcitonin may not be again that high. So all sort of situations are there. The low situation, it is crystal clear that no bacterial sepsis is, no bacterial infection is involved. And on the higher side, again, it is clear that the bacterial is involved and antibiotics are needed. Next slide. So again, all the patient will not respond in the same fashion to this sepsis. So how does it change? So it depends whether you are dealing with hyperimmune response or immune paralysis. So how you will catch that it is beyond the capacity of CRP or procalcitonin. And yeah, again, blood cultures, see blood cultures or molecular tests, again, they will pinpoint the etiological agent, what you are dealing with. They will not be able to classify what immunotype you are dealing with. So it is here this mRNA-based test, which is one of the tests is septicide, which is already FDA approved and rampantly used in United States. There you get a score. So if the septicide score is more than 15, then it is towards the bacterial type of a disease. And if it is on the lower side, it means it is a sterile inflammation. It is not because of that. And again, it is able to classify on the basis of mRNA signatures, the different type of immunotypes. Next slide. So again, this slide depicts the same. So if these are the bunch of sepsis patients, so if you are without considering the personalized medicine and without differentiating which immunotype it is there, so you will get three types of response. One will be some people will get cured, that is effective. In some cases, you will get no effect, and in other cases, you will get adverse effect. So if you have classified it clearly, whether it is hyperimmune or whether it is immune paralyzed case, because both will need different type of things. So for example, in hyperimmune, you will require IL-6 blockers or steroids, etc. In case of immune paralysis types, you will require the immunostimulants to counter this. So IL-6 will be raised in case of hyperimmune or cytokine type of response, and IL-10 will be raised in case of immune paralysis type of response. Next slide. So immunotypes of sepsis based on inflammation and immune resistant states. So this is again the repetition of same. Next slide. So this is again the importance of metagenomic, that is NGS sequencing. So how on the crime scene when somebody is investigating, although the criminal is not there, but fingerprints and hair, etc., DNA and all, they help in catching the culprit. Similarly, in our sepsis also, these DNA traces which is there in the blood, we catch hold of them, amplify them, and then we are able to pinpoint whether it is bacterial, fungal, parasitic, or viral disease. Next slide. So how the metagenomic next generation sequencing, it is a 10-year bench to bedside approach. So how this has improved the catch rate by almost 4x compared to the just conventional blood culture type of investigation. So this complements it and it gives you faster answer. And finally, further study of isolate and what is happening to it in the phenotypic terms of MICs and all, their culture will be helpful. So an independent expert panel concludes that a change in therapy should be recommended in 53% of the cases based on the NGS finding. So by and large, good correlation is there and it culminates into precision-based medicine practice. Next slide.
Dr. Malik, sorry to interrupt. It's just
Yeah,
that we are
yeah,
we are
yeah.
the
I'm wrapping up. Just give me 2 minutes. Next slide, please. Next slide. Next. So clinical advantage of faster diagnosis, helps in culture negative sepsis, detects polymicrobial infection, useful in immunocompromised patient. So only drawback is it will not be able to tell you the site of infection, etc. And of course, cost and accessibility is also a question. Right now in India, we have in all major cities, it is available, but just tier 2, tier 3 town, this investigation accessibility is a problem. Next slide. So this is helping in culture negative sepsis, immunocompromised host, fever of unknown origin, and hard to biopsy sites. So even all body fluids, biopsies, etc. are covered by this type of testing. Next slide. Next. 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 Next slide. Next. Next slide. Next. So let us now come to the conclusion slides. So don't replace cultures. Sepsis advanced complements them. Act on a big plausible hits that match the clinical picture. RNA virus, if it is suspected, separate viral PCR can be ordered. Use with stewardship. The value is realized when the result change the therapy. Next slide, please. Next slide. So what is the future direction? So we have seen the strengths and frustration of blood cultures. Where are we going in next 5 to 10 years? I believe the future of sepsis diagnostic lies in converging pathways, both culture dependent and independent diagnostics, integration of multi-omics, AI driven clinical decision support, and embedding diagnostics into stewardship and policy. Next slide. So blood cultures are powerful. Blood cultures are powerful, but must be used wisely. Embrace innovation anchored in clinical judgment, and call to clinicians rethink, refine, and collaborate. Thank you very much for patient listening. Thank you.
Thank you so much, Dr. Malik, for that insightful presentation. Now, I would like to invite our next speaker, Dr. Anup Warrior, Senior Consultant in Infectious Disease at Aster Medicity Kochi and lead for the Hospital Infection Control and Antimicrobial Stewardship Program at Aster DM Healthcare India units. Dr. Warrior has been leading voice on antimicrobial resistant and infectious control policies across India. He will focus on the issue of drug resistance, typhoid, and the role of diagnostics in combating it effectively, with insights from real case studies. Over to you, Dr. Audit.
So, good evening, all. So, I have a very brief presentation on Can you go to the first slide, please? Yeah. So, I have a brief presentation on the MDR typhoid and the focus on cultures and diagnostics, how this is relevant in terms of treating this better. Next slide. This is a snapshot of the prevalence of multi-drug resistance among typhoid worldwide. And you see that about 9% was resistant to multiple antibiotics. And about 70% of the salmonella isolated from the Southeast Asia was resistant to fluoroquinolones, which were once the drug of choice. Next slide. Coming to the India perspective, this shows is that in India, especially the fluoroquinolone resistance, which again, to come back to that being a drug of choice, is significantly increased. So ciprofloxacin resistance is to the tunes of nearly 100%. Ciprofloxacin, you see that 0 to 97%. And we have a small bit of third generation cephalosporin resistance among ceftriaxone also coming up. Next slide. Various resistance mechanisms have been described for each of these class of antibiotics, starting from traditional ampicillin, then chloramphenicol, and then sulfonamides like Cepran, and then quinolones, and finally ending up with azithromycin. And these are important in its own way, specifically when we try to choose the alternative antibiotics. Next slide. So broadly, you have plasmid or chromosomal mediated and you have core plasmid mediated. The resistance to quinolones, resistance to ceftriaxone, these two being very critical for our therapy, for the treatment purposes. This is something which we are very closely watching, and this is plasmid mediated, and this has its own impact in terms of transmission and the risk of global spread of, especially if ceftriaxone also becomes resistant, what we can call as XDR Salmonella typhi or extended drug resistant Salmonella typhi, where we are forced to use meropenem as a drug of choice in that case. Next slide. This is just a snapshot of the timeline of antimicrobial resistance in Salmonella typhi starting from 1948 when chloramphenicol was identified and became the drug of choice, followed by Septran in 1968, again followed by resistance. Then it came the era of fluoroquinolones, and by 1997 fluoroquinolone resistance happened, and in 2015 about 90% of the Southeastern strains, as you saw in India, became resistant to fluoroquinolones. Then in 2016, the first ceftriaxone resistant Salmonella outbreak was identified. However, ceftriaxone continued to be the drug of choice. Azithromycin was evolved as the next in line, and now we have sporadic reports of azithromycin resistance also coming up. And hence, we are looking at sometimes using carbapenems in this XDR Salmonella scenario. Next slide. So ceftriaxone and azithromycin now remains the cornerstone of managing typhoid in our business, predominantly because of the resistance pattern which you saw and the timeline of resistance, as you said. So based on this, we are firmly banked the backbone of ceftriaxone with or without addition of oral azithromycin. The theory being that Salmonella being both an extracellular and intracellular pathogen, having a cephalosporin like ceftriaxone to cover the extracellular serum part, and having a drug like azithromycin which would have intracellular activity may increase the difference rates and reduce relapse, still to be proved in hard randomized controlled trials, but that has been the logic of this combination. Next slide. Now, coming to blood cultures and why blood cultures for Salmonella, serology has got poor specificity because of various false positive reasons. This is a publication from 2023 which putting together the pool sensitivity of serology is being anywhere between 30% to 60%. And unfortunately, blood culture has poor sensitivity, picking it up in less than half of the relevant cases. Next slide. Of the various serologies that we use, Vidal has been the most popular, the most experienced, and most widely available. Unfortunately, in terms of its positive and negative predictive value, okay, specifically for its negative and predictive values, this has been the worst performer compared to the other serologies also, like tube agglutination tests of rapid thing and even the typhi.cart test, etc. Next slide. Hence, we come back again to blood cultures. Bone marrow is also often cultured, specifically if the patient is into the late second week of illness, where the yield from the bone marrow could be higher than the blood culture. So classically, it is believed that for typhoid, in the earlier first week, blood cultures would have better pickup. And into the second and third week, if you're trying to diagnose as an FUO evaluation, bone marrow aspirate cultures may have better sensitivity or pickup rate. In spite of all this, we know that it takes time, 48 to 72 hours, and bone marrow aspiration is a invasive test to begin with. Next slide. So how can we improve this pickup of blood culture? And the previous speaker has already illustrated the importance of volume in ensuring that your yield of blood culture is the best. So at 10 ml per bottle, which is the ideal for an adult, 8 to 10 ml is the standard thing which we fill into the culture bottle. At that, we can expect a yield of 65%, and that's max. So even at the optimum volumes of two sets, that 10 ml per bottle into two sets, still the sensitivity has gone max to 65%. So it has no further improvement was achieved beyond that. Next slide. So if you want to push further, then we put the molecular diagnostics, rapid molecular diagnostic on top of this blood culture. So you can have a blood culture system, and for those negatives, you can draw it up, and on that blood culture sample, you can run serial PCRs. And this can identify much more of typhoid, and the yield from 65 can go up to 80, 85. So that means those blood culture bottles, the even after 5 days, there is no growth. We pick up, run a PCR, and that this very low bacteremia may be identified, and therefore you may sometimes clinch the diagnosis in that fashion. Next slide. So when we saw the first slide of global prevalence of MDR, and we spoke about the drug resistance timeline, that ceftriaxone resistance coming in Pakistan, pockets of azithromycin resistance in sub-Saharan Africa, etc. One this thing is that there are a lot of quality control issues in this reporting of antibiotic susceptibility testing for the salmonella. So from the same study which you looked at, the systematic review of the global prevalence of MDR salmonella, if you focus upon the lower three parts of the table, you see that internal quality control reported it's no for 68%. External quality assessment participation reported it is no for 92%. Okay, so a lot of quality control issues exist in terms of when we look at even published literature to understand drug resistance in. Some of the things which we know in practice is that nalidixic acid resistance testing for assessing or extrapolating ciprofloxacin sensitivity is not adequate. It does not absolutely correlate with the Q, though it does in most. There are false reports, and that even for testing ciprofloxacin susceptibility, pefloxacin disc is much more better or recommended rather than using ciprofloxacin as a disk diffusion methodology. So these aspects of it, which is the method used, even if you look at the guidelines for antimicrobial susceptibility, that is the fourth heading on the right table, you see that not stated is an overwhelming 42.7%. Okay. So we have some data published, but the quality of data published specifically of ceftriaxone resistance, azithromycin resistance, even quinolone resistance, all these have to be looked at very carefully because of the background issues with quality control. Next slide. Because azithromycin is proposed to be effective even in ceftriaxone resistant salmonella, it is an efficient oral alternative to uncomplicated salmonella. Hence, testing of azithromycin should be quite reasonable and reliable. But again, when we do the disk diffusion testing of azithromycin, that again has demonstrated its possible problems, and its ability to convert into clinical practice has been difficult in terms of whether to believe the resistance to azithromycin or not believe because of the difficulty in performance and the quality control of the tests. Next slide. So to close the discussion on role of diagnostics, blood cultures in salmonella, couple of takeaway points for today are blood stat cultures remain the gold standard in diagnosis because they give you 100% specificity. Their yield may depend upon the timeline of illness, like the first week being better, second week maybe go for bone marrow cultures, etc. But ensuring the correct volume is the most simplest and effective way to achieve the maximum possible yield. You have other options like putting in molecular test from a blood culture, incubated blood culture bottle to detect low level bacteremias. But again, the volume is the most simplest and effective way. We need ideally an MIC based susceptibility report to accurately identify fluoroquinolone resistance. All of us are quite aware that the breakpoints for ciprofloxacin has been consistently been decreased from 2012 and onward. Why do we look at fluoroquinolone susceptibility and in a very focused manner? Because if fluoroquinolone is sensitive, that means fluoroquinolone resistance is absent, ciprofloxacin remains or quinolone remains the most preferred antibiotic. The fastest defervescence, least relapse, can be used orally, 100% oral bioavailability. So all these advantages are there if it is sensitive. So therefore, we look at this keenly. Susceptibilities with this diffusion has its limitations in accurately identifying quinolone resistance, as I told, because of difficulty with extrapolating nalidixic acid and even using ciprofloxacin discs. Difficulty with reporting ceftriaxone resistance, again, MIC break points proved to be better, and especially to understand azithromycin resistance, because these, especially ceftriaxone and azithromycin, remain the drug of choice in typhoid treatment as today. And we look at more reliable susceptibility testing for these specific drugs. So next slide. So with that, I end my brief presentation. Thank you very much.
Thank you so much, Dr. Warrior, for highlighting the urgent need for robust diagnostics to tackle drug resistance infection. Moving on to our next expert speaker is Dr. RTB, consultant microbiology at SIMS Hospital, Chennai. Dr. RT has extensive experience in clinical microbiology and infectious diagnostics, especially in managing challenging infections in critical care settings. She will talk about anaerobic infections and real-life diagnostic challenges, discussing detection methods, limitation of conventional practices, and how advanced diagnostics can bridge this gap. Over to you, Dr. Aarti.
Good evening, one and all. So I'll be sharing my screen. So is it visible? Visible?
No, ma'am, it is not visible right now.
Yes. Visible now?
Yes, it is visible now.
So good afternoon, all. So I'll go straight into the topic because of the delay. So anaerobe. So what are the actual challenges that we face in a hospital? So is that we'll be discussing on. So why are they challenging? So why do we need to understand anaerobes in a better way? Because of the higher mortality it can cause if it is misdiagnosed. And lab diagnosis, often it is no growth because you suspect an aerobe and you send, but the patient there will be having a huge number of symptoms and they'll be in sepsis. So there will not be any correlation between the culture reports and the patient's presentation. And it challenges in detection for labs because of the fastidious nature of the organism, because of the exacting requirements in a laboratory, and challenges in growing them, and polymicrobial nature. They often grow with aerobes. Along with the aerobes, the anaerobes also grow sometimes, so that the aerobe overgrows, making the anaerobe difficult to identify. So there's also a long turnaround time because of this for the culture reports. So finally, an empirical therapy is just started with metronidazole and clindamycin. So now no longer clindamycin is recommended, but metronidazole still it holds good. But many have even intrinsic resistance to metronidazole. So we will get into the topic. So the brighter side of an anaerobic infection. So most of them, when you identify them and you give the right antibiotics, you have an excellent prognosis. And source identification is very important, equal to identification of the bug. So debridement, removal of the infective foci play an equally important role apart from the labs. So clinical suspicion, early diagnosis, and surgical debridement play an important role in many of the cases. So what is important to improve the clinical outcome? So it starts with the clinician. So suspicion. So when do you suspect an anaerobe? So when there is a abscess with a putrid odor or a necrotic tissue is there, when you have gas, sulfur granules, then there's a black discoloration of the tissue, when you suspect some war wound on a human or an animal bite, and if there is no response to aminoglycosides, which a patient has started on. So in all these cases, we'll be suspecting an anaerobe. So now these are the typical ones, which we are already aware. So now, how do you understand the pathogenesis? So understanding the pathogenesis. So basically the anaerobe generally outnumbers the aerobe in a normal flora. So it's a part of a normal flora. It always exists as a normal flora. So in the upper respiratory tract, it occurs in the skin flora, it is there in stomach, duodenum, and wherever you take, wherever you have the organisms, it's predominated by anaerobes than aerobes. So they're always around us, they're inside us. So what do we, this is very important for the pathogenesis, because when there's a normal flora and you have disruption due to some cause, like a trauma, a surgery, a necrosis, an obstruction to the bowel, and the any foreign body obstruction, and impaired clearance because of that, any patient factors like the patient can have cystic fibrosis or any other factor like in uncontrolled diabetes. All these factors have to be looked on. So this, along with the virulence factors of the bacteria, leads to an infection. Now, from the clinical point of view, we need to identify whether the source is close to the normal flora, which I've mentioned, or a potentially sterile site which is relatively close to the normal flora for the anaerobe. Then the history and findings, which I've suggested, any previous trauma, a surgery, a viscous perforation, all these have to be looked into from the past history. Now, what are the bacteriological clues? They do have a unique morphology on gram stain, and you get clues from the clinician, like the patient is already on aminoglycoside or some basic fluoroquinolones. So another antibiotics where the which may not cover the anaerobe. So now what a lab needs at this point, a good microbiologist to suspect the anaerobic infection, to try anaerobe immediately when there is a suspicion, and to include anaerobe cultures for important specimens, at least a basic thioglycolate broth, which may be possible in many of the labs, even the basic labs. So resources, what a lab will need. PRAS, that is pre-reduced anaerobically sterilized media, or a thioglycolate medium. This is nothing but a amines transport medium with a anaerobe reducing indicator like methylene blue or something to ensure the anaerobiosis. And anaerobic transport media may be required only if the lab is going to receive samples, or you're going to send, as a clinician, you're going to send a sample to a lab which is far off. So otherwise, if it is an in-house hospital lab, you may not require this. So immediate processing, if it is there 24/7, you may not require this. And a robust system to ensure this environment of microaerophilic environment and a complete anaerobiosis environment. So you need to have some systems like automated blood culture systems and some advanced techniques like anoxomat, which I'll be discussing now. So basically the category of anaerobes, they are obligate anaerobes. There are two groups in that. One is strict anaerobe, where the exam, like Clostridium, where they cannot even tolerate 0.5% of oxygen. And the next will be the moderate obligate anaerobe, which can tolerate minimum amount of oxygen. But when the oxygen gets too much, it becomes toxic for the organism and it dies. There are also a group of aerotolerant anaerobe. Though it's an anaerobe, it will grow aerobically. So coming to this, have to suspect in case of case of anaerobe suspicion, a base of a decubitus ulcer, sulfur granules, tissue obtained from a biopsy, or a joint, or normally sterile site where septic arthritis is suspected, or pulmonary specimens where you suspect an empyema, it is very important, and GI specimens and intra-abdominal abscess, and genitourinary specimens also where you suspect any abscess in the Morris pouch or any intra-abdominal abscess, blood, bone marrow, and CSF. So transport should be rapid, and purulent samples are preferred, are important than a swab. Swabs are not preferred. So obligate anaerobes commonly cause infection that can tolerate atmospheric oxygen for at least 8 hours. So you will get your organism if you have transported it immediately. So, and mostly up to 72 hours, if you have a big chunk of your pus or a big chunk of your tissue, the organism inside remains viable. So many times we have experienced this in our lab. So fluid specimens, how to inoculate them. So the technician should be instructed to inoculate the fluid specimens to the bottom of the broth so that the anaerobiosis is ensured. Any tissue specimen has to be minced, and then we have to grind it with mortar or pestle and with a broth and treat it like a liquid specimen. Again, the inoculation matters here. So the microbiologist technician is important to recover an anaerobe. Swabs are not preferred. And if at all there is no other option like a middle layer infection where you can't get a tissue, you will have to ask for at least 2 to 3 swabs. So as a clinician, you're supposed to send at least 2 to 3 swabs, because one will be for the gram stain, one will be for the streaking, and one will go into the proper anaerobic medium. So these are the important prerequisites from the lab and the clinical side. So specimens which are not recommended: bronchial wash, sputum, because most of them are aerobes, and feces. Clostridium difficile is an exception here. Nasopharyngeal swab and secretion. So these are the sites where you don't expect an anaerobe positivity. And throat swab, unless you suspect a peritonsillar abscess, which can be caused by an anaerobe. So voided and catheterized urine also, you don't have any reports, very, very rare reports of anaerobe. So it is better to you have to reject these samples in case you have received for an anaerobe culture. And next, only suppose this is the broth that we'll be using. So based on the growth characteristics. So if the growth is at the bottom, the turbidity at the bottom, a microbiologist can suspect the anaerobe. And if it is subsurface, which is microaerophilic, so that is also occurs along with that. It is also a type of, and it can also be an anaerobe. So these are the times where we suspect anaerobe and go for further workup. Now, let me go into some of the cases, interesting cases that we have had for the past 2-3 months. So a 60-year-old, this is a current case right now in SIMS hospitals. So 60-year-old male presents to ER, referred from another hospital with 1 day duration of slurring of speech, deviation of mouth, discoordination of both limbs, but he was obeying to commands. So probably they did a presumptive diagnosis of acute CVA. The GCS was E2, V2 and M5. So proper right side paralysis with the upper lobe power of 3/5 and a lower limb power of 1/5. So total counts were not done because there was no suspicion of an infection. So it was an acute CVA and CT plane with a hypodense lesion, which you can see here, a hypodense lesion with a rim of hyperdensity. So here the left gangliocapsular region was involved. So a SOL was suspected. So and query mitotic with a midline shift. So severe and so big was the SOL. And contrast MRI was suggested. But in contrast MRI, on the contrary, we had a diagnosis of left frontal pyogenic abscess with a perilesional vasogenic edema. So which you can see here, a big hyperdense lesion which is suggestive of a pyogenic abscess. So now injection meropenem and vancomycin was started and craniotomy was planned subsequent to this diagnosis. And after the craniotomy, samples were further sent for diagnosis. So gram stain, what we did show plenty of Gus cells and it showed plenty of gram-positive cocci in pairs. A striking gram stain where the GPCs are tinier than the routine aerobic staphylococci or streptococci. So the first day, it was no growth. So on seeing the gram stain, we had a suspicion of an anaerobe because it came late evening. So we had to see on 13th. So we had a suspicion of anaerobe and anaxomat was loaded. So it's basically, it is a machine that provides anaerobic environment. So we got tiny colonies, which on MALDI showed Streptococcus intermedius. So this is a microaerophilic organism. So this may grow in routine culture, but it may take 5 days. But if you provide a proper anaerobic environment, it grows in a day. So remarkable improvement for the patient because following the susceptibility testing, injection ceftriaxone was started. So remarkable improvement. The patient was discharged yesterday with a total count of 9,170 and power improved to 4/5. So this is one of the success stories. And the patient's gram stain, which is on the left side, this sample and actual gram stain of aerobic streptococcus. So when you see the difference in the size of the bacteria, see the pus cells here and here look the same, but look at the size of the bacteria. It is very tiny compared to the streptococcus, aerobic streptococcus. So this should arouse a suspicion of an anaerobe. Once you see such a sample, always to put it's better to put parallel anaerobic cultures along with your aerobes. Next is a case 2, a female patient, 58 years, a recurrent case of atypical meningioma who had had previous surgeries, one a year ago, another 10 years back, type 2 diabetes, poorly controlled. So she had a third surgery on 38. So following this, after a week, she comes back to the hospital with 1 week of ear discharge. So this time, the last time the surgery happened was in the temporal and pterygopalatine fossa. So following which she had a left ear discharge, and a presumptive diagnosis of SSI was done, and the dressing over the left ear was removed, and a profuse small foul-smelling discharge, purulent discharge, and on while they were just giving a dose or the wash, the anterior wall of the external auditory canal was communicating with the operating site of the infratemporal fossa. A limited wound wash was given with hydrogen peroxide and suggested admission. So CT plane showed the subgaleal edema and emphysematous changes in the left temporal and the zygomatic region in the cheek area. So meanwhile, the patient was taken up for re-exploration and debridement to control the damage and the infection. It's because it was foul smelling, anaerobe was suspected. So they had sent anaerobe cultures from the ear actually at this part itself, at the first time itself when they were giving a wash. And meanwhile, the patient was taken up for re-exploration and further cultures were sent from temporal and zygomatic region. The inferior part, so the surgery was done with some removal of temporalis muscle and a thorough wash with Metrogyl was given. And communication was there because of the previous surgeries, and the destruction was extending to the TM joint also, temporomandibular joint. Now, anaerobic culture of the ear, it reveals Streptococcus viridans, anginosis, and Egerthia catenaformis. So it's a polymicrobial infection. So Streptococcus viridans and Strep anginosis. So viridans, we are not sure whether it is a pathogen, but because of the situation, complicated situation where the patient is, because of the previous surgeries and other things, we did consider give importance. And Strep anginosis, a potential pyogenic infection, it causes a lot of abscesses. So when the sensitivities were done, anginosis was sensitive to penicillin, but Strep viridans, we know because of the penicillin resistance observed, we suggested ceftriaxone. Egerthia is a gram-positive bacilli, anaerobic gram-positive bacilli. It was very foul-smelling, and it's generally treated with penicillin and ceftriaxone and other beta-lactams, high-dose ampicillin. So together, to treat all the three together, we did start on injection ceftriaxone, and the patient was on ceftriaxone for 2 to 3 days in the hospital and discharged with improvement. So now this is the gram stent, again the tiny GPC, and we could also see the GPB in the arrow shown. So the GPB, the Egerthia catenaformis, which was causing the, which is adding on to the infection. Now the case 3, 62-year-old female with paraplegia and recurrent DJ stenting and diabetic. So she had history of fever. So on seeing the CT, there was a increased dilatation of pelvic calyceal system, and blood cultures and urine cultures were given, and DJ stent was removed, and the patient was started on meropenem. Again, the imaging revealed a bilateral pyelonephritis, and this is the left kidney showing the perinephric stranding and a exophytic collection. There was also a collection observed in the CT. And finally, the blood culture showed GND. And PCR reflex testing is done in SIMS. So once it was done, Bacteroides fragilis was identified and the patient was started on Metrogyl. So this PCR served the time so much. So once the blood culture showed GNB, within an hour, we gave the report as bacteroids, and following which the patient was started on Metrogyl. So parallelly, as urine cultures were also sent, significant growth was there for Klebsiella pneumoniae, carbapenem resistant, and Proteus mirabilis. This patient is a paraplegic patient on chronic catheterization. So in this situation, will you treat this Klebsiella pneumoniae? So better not to treat, because these are all colonizers, which is observed in a chronically catheterized patients. So the patient was treated for a couple of days for Metrogyl, and then she was sent home with Metrogyl and now recovered. Case 4. So this is a very interesting case. So 57-year-old female with multiple episodes of vomiting. So further imaging, suspecting the urosepsis, which is a commonest form of sepsis, showed bilateral pyelonephritis. We can see the significant fat stranding on the left side and some on the right side also. So cystitis was also observed. So she was a case of diabetes, hypertension, and DJ stenting was planned. So acidosis, tachycardia, and slowly the blood cultures and urine cultures were sent, which is a norm. So blood cultures showed a GNB and urine cultures E. coli. So further reflex testing on blood cultures revealed E. coli and CTXM. So CTXM, so it is an ESBL where we have to treat with meropenem. Your BLIs will not, combinations will not work. So the patient was immediately started on meropenem. So patient recovered after. So now here it is a straightforward case. So what relationship it has with the anaerobe? So which we will tell you. The case was very interesting from the microbiology perspective. So what is so new here? So lab subculture from the Bactec bottles revealed no growth. So we thought hot loop was used. Probably the patient, the technician had wrongly inoculated with a hot loop, so the bacteria had died. So we again did a subculture, which also showed no growth. Then we tried the anaerobic subculture and it showed growth. Now we had another confusion. So was the PCR wrong? So because the PCR revealed E. coli and the CTXL, so was it wrong? So when we were troubleshooting that, we thought, could it be a mix-up? But there was no other sample which was running along with this PCR. So we didn't know where the answer was. And finally, the MALDI was done, so which revealed the ID as E. coli. So why was there an anaerobic switch to this from a facultative anaerobic to anaerobic switch? So E. coli, we all know, is an aerobe, but here there is an anaerobic switch that has happened. So we could perform only the manual AST because the organism was not growing only aerobically. So we could not do the MICs and other things. So we did a manual AST. So the isolate was further sent for CMC for further workup. So we are waiting for the answers. And anaerobe workup. So as I already told, the gram stain is very important because of the size, shape, even the spore bearers, we can identify the spore shape and other things. Still the basics, stick to the basics. Basics are very important. The cultural characteristics, biochemicals are there, manual, they are extensive. Automated biochemical systems are there, and automated blood culture systems are there, and gas liquid chromatography and high performance liquid chromatography, all these are there. So these can occur. The GLC and HPLC can be done only in a research center and may not be possible in a normal lab. So high-end labs may have MALDI-TOF, some labs may have gene sequencing, but so with this, how do we proceed? So what are the other things that we can? So this is the Annexomat. So the Annexomat system. So we create an anaerobic environment. We create, so we replace the oxygen with the whatever is the gas that required nitrogen. So we can create capnophilic environment, microaerophilic environment. So just touch a button and it is connected to the cylinders and it will give that environment which we want. And the jar is placed in the incubator for further growth. And our Macintosh Fildes jar, the gas pack, which is very much possible now. So with a jar and anaerobe glove box. So this also all this can occur only in glove box, can be got only for a research center. And not, but least but not the last, the Bactec bottles, which is very important. So BD has introduced this Lytic anaerobic system, which has bottles which have saponin. So this will help in releasing the intracellular bacilli. So this is very helpful for a quicker diagnosis. And there subsequently are superior recovery rates of anaerobes and facultative anaerobes. And the BD plus anaerobic medium with resins. So this here, the resins have a huge role because they can bind the antimicrobial agents. So many of the patients where the blood cultures are taken are already on antibiotics, treated outside and referred to the next hospital. So when we take, there will be residual antibiotics. So these resins help in binding and allowing giving a favorable environment for the bacteria to grow. So HPLC, as I told, it's a very complex system. It identifies the volatile fatty acids produced by the anaerobic bacteria and gives a presumptive identification. And MALDI-TOF, so MALDI-TOF is a new technology where it measures. So a small smear is made on the slide and kept. It is exposed to the laser It's just loaded into a machine and the machine gives you the ID. So the laser will actually break it into ions and it will go through a time of flight. It will go through a tube called flight tube. So depending on the charge and the mass of the particles, it's basically a proteomics based technology. And finally, it will go and hit the detector and it will produce a specific pattern. We need not bother about the pattern. The AI takes care of everything. The machine analyzes the spectrum from the library available and compares it with the spectrum of the patient's bacteria, and it will give the diagnosis. This cannot be performed on samples. This can be performed once the culture is ready. Gene sequencing, whole genome sequencing. It's a novel technology. It's a culture independent testing. It's now considered as a gold standard. It can be done directly on the sample, and complete sequencing is done, and it is compared to the already available genomic libraries to identify the organisms available. So this is the study comparing the Malditov and the whole genome sequencing. So what are the advantages and what are the disadvantages? Malditov is rapid and simple, whereas whole genome sequencing is more time consuming and more laborious, so which can occur only in a proper genetic lab. So Malditov is cost effective compared to the whole genome sequencing. Running cost in Malditov is quite cheap, whereas the machine is costly. So the ability to identify to species level is 65 to 90% the variable reports in the studies. Whereas whole genome sequencing, it is superior, it identifies because it's a gold standard, it identifies everything. Polymicrobial infections, they have a poor performance in Malditov because we have to isolate it separately before we go for Malditov identification. And polymicrobial infections here, WGS performs better. So Malditov, there it is less accurate to identify less characterized or rarer anaerobes, whereas WGS identifies them or even a new pathogen quite quickly. So in SIMS Chennai, what is our anaerobic workflow? So if it is blood culture positive, the reflex PCR takes care of the thing. Though the reflex PCR has only it's a multiplex PCR which has only Bacteroides fragilis in the panel. So any other suspected samples or any other blood culture positive not growing aerobically will be loaded into the Annexomat. So they are kept in the incubator. The next 24 to 48 hours, once the growth occurs, they are identified by MALDI and subsequent AST testing occurs. So what for the other labs? So how do we make the other labs where you don't have such facilities? Pure identification. So anaerobic GNB, so we can presumptively identify the anaerobic GNB to which group they belong by keeping these three discs, vancomycin, kanamycin, and colistin. And this chart will help in presumptively identifying them to the group to predict the appropriate therapy. So anaerobic AST. So it is not recommended to do anaerobic AST often because you can predict the AST to some extent, like based on the ID alone. But it is a challenge because CLSI recommends MIC, which can be performed only if the glove box is available, which is not going to be there in many of the labs. Next, agar dilution technique, where the agars with varying concentration